All right, let's dive right into this. Welcome to the Explainer. So today we're tackling a topic that honestly often feels like a massive, stressful medical hurdle. But I promise you it absolutely doesn't have to be. We're looking at arterial blood gas, or ABG analysis. Instead of just kind of staring blankly at confusing lab results and trying to memorize random strings of numbers, we're going to treat this whole thing like a foolproof, step-by-step medical detective process. By the end of our time together, you're going to be solving these clinical cases like an absolute pro.
Here's our mental roadmap for today. 1. Taking the ABG sample. 2. Core values to know. 3. Acidosis versus alkalosis. 4. The Rome technique. 5. Understanding compensation. And 6. Real-world clinical scenarios. Now, let me reassure you right now, sticking to this strict chronological structure is your absolute key to success here. Trust the process, don't skip ahead, and you'll completely master ABG interpretation by the time we wrap up.
Okay, Section 1. Taking the ABG sample. Getting started. Let's head right to the patient's bedside, because before we can analyze any numbers at all, we've got to talk about drawing the physical sample and the serious precision this very first step requires. So picture this. You're at the bedside, you're drawing the sample, and oops, you accidentally prick a vein instead of an artery. The blood flowing into your syringe is venous blood. What do? This is a super high-stakes scenario. And actually, it's a notorious trick question that pops up constantly on major nursing exams like NORCET.
Well, the answer is absolutely emphatic. You discard that blood and retry immediately. I mean, the A in ABG strictly stands for arterial. It must be an arterial sample. You simply cannot use venous blood to run an arterial blood gas analysis. Doing that literally defeats the entire purpose of the test.
So, when you are actually ready to draw that arterial sample, you've got to follow a firm anatomical priority list. Your first priority? The radial artery, right there in the wrist. Now, if that's not viable for some reason, your second choice is the brachial artery in the arm, followed by the femoral artery in the groin as your backup. Oh, and here is an absolutely critical detail. You must use a heparinized syringe. That heparin coating is what prevents the sample from clotting before it even reaches the lab.
But wait, hold on. Before you just go poking that first priority radial artery, you actually must perform the Allen test to check the patency of the ulnar artery. Here's how you do it. First, extend the patient's hand. Then, compress both the radial and ulnar arteries with your fingers and ask the patient to squeeze their fist. After that, release only the ulnar artery. What you're looking for is the hand to return to a nice pink color within 6 seconds. If it takes more than 6 seconds for that pink color to come back, that means there's an obstruction or narrowing in the ulnar artery, and you must not use that radial site. It's totally unsafe.
Section 2. Core values to know. ABG baselines. So, the crucial point is, once you've successfully sent that sample off to the lab, what are you actually looking at when the results come back?
Well, these 3 metrics are the foundation of everything that follows, so do whatever you have to do to lock these numbers into your memory. A normal pH rests right between 7.35 and 7.45. Normal CO2 is 35 to 45, and normal bicarbonate or HCO₃- is 22 to 27. You really have to know these baseline numbers cold if you're going to be an effective ABG detective.
And check out the clear division of labor in your body here. Bicarbonate, or HCO₃- is directly tied to your metabolic conditions. So if there's an abnormality there, boom, it points straight to a metabolic issue. On the flip side, CO2 is tethered to your respiratory system. So CO2 abnormalities, they flag a respiratory issue. They each have their own totally distinct domain. Now that we've met our core players, let's dive into Section 3, acidosis versus alkalosis, decoding the pH. We're going to look at the overarching bodily conditions based solely on our very first metric.
This rule is incredibly simple, but it is entirely non-negotiable. Remember that normal pH range of 7.35 to 7.45? Well, if your patient's pH drops below 7.35, they are in a state of acidosis. If the pH rises above 7.45, they're in a state of alkalosis. Simple as that. Establishing this extreme is always your very first diagnostic step.
Okay, here's where our detective work gets really fun. Section 4, the Rome technique, your ABG mnemonic. We are officially moving into what is easily the most powerful and reliable tool in all of ABG analysis.
So, Rome stands for Respiratory Opposite Metabolic Equal. Let me say that again. Respiratory Opposite Metabolic Equal. Memorize this phrase. This simple little acronym is the absolute linchpin for linking your patient's lab numbers to a final concrete diagnosis. Let me show you exactly how this operates in practice.
And this brilliantly illustrates exactly how Rome decodes the whole mystery. Let's look at the metabolic row first. Metabolic is equal. That means the arrows for pH and bicarbonate go the exact same way. So, for example, if your pH goes down and your bicarbonate goes down, that's metabolic acidosis. Now, take a look at the respiratory row. Respiratory is opposite. The arrows go in opposite directions. If your pH goes down but your CO2 goes up, that's respiratory acidosis. Just match the arrows and you match the disease. It's like a giant puzzle and you've got the key.
But listen to me carefully here, because this is where students get tripped up all the time. Exam questions love to scramble the data just to mess with you. They might throw the CO2 at you first, then bicarbonate, then pH. You have to ignore their order and always stick to the golden sequence. Step 1. Always check the pH first to determine acidosis or alkalosis. Step 2. Check the bicarbonate. Step 3. Check the CO2. If you follow this chronological sequence every single time, you will never get tricked.
All right, let's move into our next phase, which honestly covers what is arguably the most advanced but also the most commonly misunderstood topic in all of ABG analysis. Section 5. Understanding compensation, the backup plan.
To truly grasp compensation, I want you to ask yourself this question. When your primary bodily system is sick and failing, what is your body's backup plan? Like, how does it actively try to save you from severe acidosis or alkalosis?
Well, the answer is always found in the pH. If the disease is fully compensated, it means your body's backup plan worked flawlessly, and your pH has returned completely to the normal range. Whether the root cause was respiratory or metabolic, if that pH is back resting comfortably between 7.35 and 7.45, the condition is officially considered compensated. The body fixed the critical imbalance.
But what if the pH isn't completely normal yet? Think of it using this brilliant friend analogy. Imagine your metabolic system is sick, right? Well, its best friend is the respiratory system, the CO2. If you're sick, your best friend should be frantic, running around trying to help you out. So, if you have a metabolic illness and your friend, CO2, is showing abnormal levels, meaning it's actively altering itself to fix your problem, that is partially compensated. Your friend is trying. But if you are suffering and your friend CO2 is totally normal, like just sitting lazily on the couch doing absolutely nothing while you're sick, that's uncompensated. The backup system hasn't even started trying to help you out.
Let's move to and see how this all builds into our final and maybe most important phase. Section 6. Real-world clinical scenarios. It's time to apply all these rules to real patients.
These are extremely high-yield clinical scenarios you are definitively going to encounter on exams and out on the hospital floor. Let's rapid-fire through them. First, continuous vomiting. When a patient vomits continuously, they lose massive amounts of stomach acid, or hydrogen ions. Losing that acid leaves excess base behind in the body, which directly results in metabolic alkalosis. Severe diarrhea, conversely, causes a massive loss of base, leading to metabolic acidosis. Now, if a patient has an airway obstruction and simply can't breathe out CO2, that trapped CO2 builds up and creates respiratory acidosis. And finally, if a patient is hyperventilating, breathing way too fast and blowing off way too much CO2, it rapidly triggers respiratory alkalosis.
So, armed with the precise rules of the Rome method, the unbreakable logic of the golden sequence, and a really solid understanding of how your body's friends compensate for illness, I have one final question for you. Are you ready to flawlessly solve the medical mystery of your next patient? Because I guarantee you, with these structured tools in your back pocket, you are now fully equipped to tackle your toughest exams or your upcoming clinical shifts with total confidence. Keep practicing this step-by-step process, and you'll be an ABG expert in no time. Thanks for learning with me today.